Good day. We're still busy with the Mother Baby Friendly Initiative series. I'm still Anna Nolte, and today we are going to do lesson 2, which is the assessment of the baby to the breast. Okay, so in this lesson, we're going to talk about attachment to the breast or latching. And I think we all understand or will understand that latching is one of the most important aspects of breastfeeding. I think the total success of breastfeeding to a very large extent depends on good latching or good attachment of the baby to the breast. Now, the definition of latching refers to the way the baby attaches to the breast, and this is one of, as I've said, the most important aspects of breastfeeding, because if the baby is being attached or latched correctly to the breast, it promotes high milk flow. And as you will remember from the physiology that we have done, it's the most important aspect of producing milk. We've said that the more milk the baby is removing out of the breast, the more milk will be produced. More prolactin is being secreted and more milk is being produced. So this is very important for the total production of milk, and in the same time it also minimizes nipple discomfort, so it minimizes problems with the nipples like sore nipples. um, for in general. So for when there's poor latching, there will be obviously poor milk transfer. The milk production will eventually go lower and eventually will stop. And there's also the possibility of sore and cracked nipples. Now, in good attachment, it's important to assess the position of the infant's mouth on the breast, and we have done that to a large extent in the previous lessons, in the previous session and the previous lessons, where we looked at specifically how the infant is suckling. Now, if we look at this picture, the picture and this diagram, for example, the infant, and as we have said previously, the infant should suck not only the nipple into his mouth, but also a part of the areola, so that about 2,5 to 3,8 centimeters of the areola is also being drawn into the baby's mouth. We have said in the previous session that when the baby is drawing the nipple into his mouth, it makes the nipple about 3 times as long as it normally was. So when the baby is suckling now correctly with the nipple into his mouth as well as the part of the areola, it prevents the baby from sucking on the on the nipple only, which might lead to sore nipples, which we will come uh, later on back to again. And it also prevents insufficient milk production, because the baby gets now presses with his gums on this um, distended ducts, milk ducts here behind the areola, and he gets the milk into his mouth. And most of the areola, as we've said, is covered by the baby's mouth, and specifically more of the areola on the underside of the baby's mouth, on the bottom side of the baby's mouth. Now, when we look at poor assessment, as you can see on these photos and this diagram, what happens is that the baby almost have nothing of the areola into his mouth. His mouth is not wide open, and he's only drawing basically the nipple or the part of the nipple into his mouth. And his chin is far away from the breast in comparison with latching, where the nipple is right onto the breast. Now, if we look further up to the position of the mother and the baby in latching, it's very important to teach the mother to identify the cues when the baby is hungry, like we've said previously, so that the mother starts breastfeeding the baby while there's still mild cues of hunger, instead of waiting till the baby is crying and being unhappy and being uncomfortable and not drinking properly. Now, we've also said that the baby should be awake, because it's very difficult to try and latch a baby onto the breast when he's sleepy, and the baby should be hungry, so that obviously he will almost happy to be put to the breast. Now, if the baby has been put skin to the mother's body, it might help a lot with the latching, and especially in the first week or so when latching might be a problem. Because first of all, we have talked about all the advantages of skin to skin contact in the very first breastfeeding experience. And also, in this case, where there's a very sleepy infant, it might awaken the infant a little bit, and also it might calm a very upset baby that's very cross and crying a lot. It helps to calm him down a little bit before he's been put to the breast. Then also a very important aspect regarding latching and putting the baby to the breast is that the midwife should use a non-touch, hands-off technique at all times, and that's very important. We have talked about it a little bit in the very first session where we talked about the communication skills. It's very important for two reasons that the midwife should have a non-touch hands-off technique. The one is, we all know that when you get something right on your own by yourself, it improves confidence a lot, and we have talked a lot about improving the confidence of the mother, so that's very important. And the other thing is, we've also said that we should have respect for the mother's wishes, her body, her cultural aspects, the cultural aspects about around the breast, etc. So we should always ask for permission before we touches the mother's breasts, and that's very important. Now, I think we're all very kind of impatient, and not in a negative sense always, but impatient in the sense when the mother is really struggling to get the baby to latch to the breast, to help to put the baby to the breast and to help the baby to suck. And as we've said, that might be more wrong than good. So midwives should use a non-touch hands-off technique except when the mother really requests it. And if we see that the mother really struggles, we can ask for her consent to touch the baby, touch the breast, and really help her with the breast. And then also, what's very important for the latching and proper latching is the comfortable position of the mother and the baby, as we've said in the previous lesson. The mother should be in a comfortable position and the baby should be in the correct position with a full frontal contact of the baby's body with the mother's chest, so that his body is being turned towards her. And this is the best way of helping the latching process on, or encouraging the latching process. Now, the baby should be snuggled securely in his mother's arms and facing her, and this also helps the mother to maintain eye-to-eye contact with the baby, which might be very positive for specifically the mother. And remember, we have said that when she's experiencing a positive experience with the baby, it also helps with the secretion of oxytocin, which helps to a large extent with the letting down reflex. Now, when we talk about the positioning of the baby to help the baby to latch, there are certain principles here that's also very important for the latching process. And first of all, very important that there should be no pressure on the back of the baby's head. We've said that it's very easy when you press on the baby's head to press the baby's head into a position of flexion. And we have said it's very difficult for the baby to really suck when his head is in flexion. So as you can see on this picture here, the baby's head is almost a little bit extended instead of in flexion. That helps the baby, and we've said that the mother should not push the baby's head towards the breast, but just support the neck and the bottom part of the head here with the hand, specifically when the mother holds the baby in a cross cradle position. And that helps the baby's head to be free so that he can move it onto the breast if he opens his mouth widely, so that he can grab the nipple and get it into the correct position into his mouth. As we've said, the mother should support the breast with the hand, And very important to keep her thumbs and her fingers away from the areola so that there's more than enough place for the baby to get as much as possible of the areola into his mouth. And as you can see in this picture, the ideal position is for the baby to have, before he latches, to have him so that his nose is opposite the level of the mother's nipple. And that helps with stimulating the root reflex. It will help him to open his mouth widely. And you will see also on the video that if this is the correct way for the baby to get the nipple into the correct position in his mouth, so that the nipple is facing into the direction of the palate, and he can suck the nipple into the almost, I want to say, a posterior position in his mouth. If his mouth is right opposite the nipple instead of his nose, he doesn't open his mouth wide enough, and it's very easy for him to then just grab on the nipple, and instead of getting the full areola part in his mouth as well. And then very important that the baby's chin should be in contact with the mother's breast and not far away from the mother's breast, as we've seen is the position in when the baby is not latching properly. Now, when we look to the again a little bit more, in more detail, to the position of the baby to latch, we will see, like in this first photo, the nipple was opposite the baby's nose. The nipple, the baby uses this to stimulate the nipple, basically stimulate the baby's rooting reflex, and that makes him to open his mouth widely. And then the mother can bring his shoulders, not his head, because if you push his head closer to the breast, it causes his head to go into flexion. So she brings his shoulders closer to the breast so that he comes closer to the breast, and that he can get suck the nipple and the areola then into his mouth. And his mouth should be widely open in order for him to get this whole part of the nipple as well as the areola into his mouth. If he's not open his mouth widely, it will compress the end of the nipple, and that will cause trauma and pain and little milk flow. Here you can see a checklist for latching to make sure that the baby has been properly latched on the breast. When you are doing attaching the baby to the breast, you can make sure that if the baby's mouth is wide open, is her chin up and pressed onto the breast, is the baby's body in a straight line. We've said so many times now in the first lesson with the positioning of the baby and the mother. Is the baby's mouth covering the nipple as well as the areola underneath as well? Is the breast deep into the baby's mouth? Are her lips spread wide? And we will come to this again. Is her nose free from the breast? Can she breathe properly? Does she start sucking immediately, switching to long, deep sucks? Now we will come to the different sucks and the different ways in which the baby is sucking just now. Do her jaws move and her ears wriggle slightly during swallowing? And stop the feeding if the cheeks are going in and out. And you will see this very clearly on the video as well. The difference between when the baby is sucking properly and when the cheeks are going in and out, which shows that the baby is not being latched properly. Does the mother have eye contact? Is the sound of the milk being swallowed? Does she experience the let down reflex? We will talk about that a little bit more. Does she allow the baby to feed on the one breast as long as possible? We'll talk about that as well. When releasing the baby from the nipple, does she break the suction? And we will talk about that as well. If the baby refuses to open her mouth wide, does she gently brush the top lip with a nipple to trigger a gape reflex? Now, if we look at this first up to here, is a nose free from the breast, these first aspects, that means that will show us that the baby is being latched or attached to the breast well. And these other criteria that's been from the jaws to the sucks, swallowing, etc., tells us that the baby is getting milk and proper milk from the breast in such a way that there's enough milk to swallow. Signs of a good latch. From the outside, if we look at the outside, at the baby's mouth and the breast, we will see that the mouth is opened wide like a jaw before the baby is attached to the breast. First of all, the rooting reflex has been stimulated by the nipple that's opposite the baby's nose, and then the baby will open his mouth wide enough like a jaw, and then the baby's tongue is over his lower gum. We can see a little bit of the tongue here on this diagram. Sometimes we can see the tongue and sometimes we cannot see the tongue, but it's very important that the tongue is here over the lower gum and here in front of the baby's mouth, because remember when we talked about the way in which the baby suckles. We've said that the baby is the milk comes on the baby gets the milk out of the breast by pressing on the gum with the gums on this distended areola, distended milk ducts here, and then the peristalsis milk, the tongue basically follows a peristaltic pattern to move the milk backwards so that the baby can eventually swallow it. The baby's lips are curled out like you can see here, almost like a fish. The very important is that the lower lip should be curled out. Sometimes the lower lip is being curled in or is being inwards, and that is a definite sign that the baby is not being latched well. And then very important that the latch is comfortable and pain-free. The mother should not feel any pain when the baby is suckling in the right way. Now, when we look at other signs of a good latch, we see that the baby has taken much of the areola into his mouth. The larger ducts are also being included in this underlying tissue, so he can, with his gums, press the milk out of the larger ducts and literally get the milk into his mouth. And we've talked a lot about the fact that he stretches the breast tissue out to form a long teat, and that this teat is about 3 times as long as the nipple itself. And if we really look closely, we see that the nipple only forms 1/3 of this teat. The other 2/3 of the teat is basically being formed by the areola that he also sucks into his mouth. And the baby is then basically suckling from the breast itself and not from the nipple. And as we've said, the tongue is forward over the lower gums. And as we've said previously, the tongue is cupped around the teat, around this teat that the baby has sucked into his mouth, so that the tongue literally forms a cup, a trough in which the nipple is lying. And then we have said this also several times now, that when the baby sucks effectively, it does not rub the skin of the breast, so there's no friction of the skin of the breast or the nipple, so this should not cause sore nipples if the baby is being attached correctly to the breast. And then very important, such attachment as we've seen here, when the baby is now has drawn a lot of the areola as well as the nipple into his mouth and is getting the milk from this distended ducts, it will stimulate the emptying of the breast. And as we've said many times before in the previous session when we did all the anatomy and physiology, that the emptying of the breast is the best stimulation for the breast to produce more milk. So the better the breasts are emptied, the more milk is being produced. When we look at poor attachment, what happens there is, because the baby is only sucking on the nipple and he's trying very hard to get milk out of this nipple, he sucks very hard, and this pulls the nipple in and out of his mouth as he's like literally sucking the nipple in and out, and this causes a lot of that the skin rub against the baby's mouth, and this then causes the damage to the nipple, and that causes sore nipples eventually. The baby also sucks with fluttering movements instead of proper long sucking movements, and we will look at the difference between all these different sucking maneuvers just now. When is it good sucking and when is it not good sucking? But in this case, with poor attachment, the baby will suck with these fluttering movements all the time instead of proper sucking movements. And because the baby is not removing milk from the breast effectively, we might end up with engorged breasts, which is then a very painful condition for the mother, and that inhibits the latching and the attachment then further. It also causes, because the baby is now not getting enough milk from the breast, he might get a little bit of milk from just sucking on the nipple, but he doesn't get enough milk from the breast because he's not getting the milk from the distended ducts. It makes that he's unsatisfied. He cries soon after the breastfeeding. He's not happy with breastfeeding as such, and then he also cries a lot afterwards, which says that the baby doesn't get enough food. And he often wants to feed more and feed for a longer period than normally. And as we have also said now many times, because the breast is not being emptied properly, it doesn't make enough milk, doesn't produce enough milk, and we literally get a bad cycle, and the baby is also not gaining enough weight. So eventually the mother might feel that she's a breastfeeding failure. She loses confidence. She's not relaxed. The lay down reflex doesn't work. And as I've said, it becomes a bad cycle. Now, what are the so-called latching difficulties? What makes latching difficult for both the mother and the baby? Now, what we can do in assisting the mother with latching is, first of all, to encourage the mother to continue with skin-to-skin contact. As we've said, when we talked about the different positions, it might be if the mother is really struggling with latching, or the mother and the baby is struggling with latching, that we can put the baby into the same position on her tummy, on the mother's abdomen, like we've done with the first breastfeeding session. Encourage skin to skin and help the baby to find the breast on his own, and very often that might help. We also need to teach the mother the hunger cues, that she start feeding the baby when it's hungry and not wait too long before the baby starts crying and then is angry and not calm and doesn't want to suck. Also, she shouldn't start too early by waking the baby up when he's still fast asleep and is not really interested in the breastfeeding. If all these doesn't work, then we also need to perform a physical assessment of the mother's breast to see whether there might be any problems with the mother's breast, like inverted nipples or flat nipples or things like that. And that we will come to in the last session when we're talking about all the maternal problems. We will definitely come back to this as well. Or we need to assess the baby for factors that might also inhibit sucking or the latching effect. For example, the baby is lethargic because of hypoglycemia or sepsis or dehydration, or there are any other problem. And obviously these problems need to be reported to the doctor so that it can receive the necessary attention. We also need to look at the baby's mouth, because there can also be problems in the baby's mouth, like a tight frenulum of the tongue, where we have a so-called tongue tie, a tight tongue, sorry, which means that the frenulum of the tongue is very short, and it makes that the tongue can't really move forward effectively for the baby to latch. And this is usually an easy problem to solve, because this tight frenulum has just been cut, and that makes enable the baby to move his tongue forward. Or also an excessive receding jaw, specifically if the lower jaw is very, if I can almost call it like in short. Also, again, it makes that the baby can't press the milk out of the distended ducts, and that influences the sucking ability of the baby as well. If we are a little worried about the sucking abilities, if we think that the sucking reflex is not being developed well enough, or there are some other problems with the sucking abilities, we can put our finger in the baby's mouth, obviously a clean finger, and to see to what extent the baby is sucking. When the expectation is that touching the soft palate will result in a sucking response, and then we can determine whether the baby is sucking well, whether the sucking reflex has been developed well. Very important is that we should, and I know that mothers get very easily depressed, and we too, when we are struggling to get the baby to latch and it doesn't really work. The easiest thing is to grab a supplement because the baby is unhappy, the baby is crying a lot, the baby gets hypoglycemic, etc. So it's very easy to grab for the supplement, and we will talk about supplements in detail also in the next two sessions that we will talk about. So it might be a better solution to try and wake the baby up and do more often breastfeedings of at least 3 hours apart and during the day and the night, and also try to breastfeed the baby for at least 10 to 20 minutes to make sure that the baby at least gets some hind milk as well, and not only the fore milk that we've also talked a lot about previously. And if the latching is still not successful, to feed the baby with expressed milk instead of formula. It says here to feed the baby with expressed milk or formula, but the best solution is to do with expressed milk, and that we will talk about in detail in our next session. And encouraging pumping of the breast, expressing milk from the breast, which we will talk about a lot. And then also very important is to check the mother's use of deodorants and perfumes or body soaps with a strong odor. Remember, we've said in the first breastfeeding experience where the best baby is being put to the breast for the first time, the baby is going after the smell of the breast milk. And the same even here when we latch the baby still goes after the smell of breast milk because he knows the smell of breast milk. And if there's deodorants or the mother uses deodorants or perfumes with a strong odor, that might so-called, I want to say, mask almost the smell of the breast milk, and that might make the baby not to latch properly or interfere with the latching. Also, the baby might just not like the smell of the deodorant or the perfume. Now, when we look a little bit further at the suckling pattern, and these are also some of the cues that we need to teach mothers. How should the baby suck if after the baby has now been latched to the breast or attached to the breast? How do we know now that the baby is getting milk from the breast? And this is very important that we look at the different suckling patterns of the fetus, of the baby, but that we should also teach that to the mother so that the mother can also determine whether her baby gets enough milk or not. Now, we distinguish between the so-called nutritive suckling and non-nutritive suckling, which we will come to just now. Nutritive suckling means the baby gets milk into his mouth, he sucks it, he swallows it, and he gains from it. So the nutritive suckling, when the baby is doing nutritive suckling, he sucks with smooth, continuous movements and with occasional pauses to rest, and we will come back to this just now. The infant might swallow after each and every suck, or he might suck several times before swallowing. Now, this depends on a large extent. This pauses to rest, as well as how often he sucks, depends to a large extent on the lay down reflex. As we've said previously, the lay down reflex comes in waves. It's not a once-off kind of reflex that the oxytocin is being released and the baby is, the lay down reflex happens. We've said that the oxytocin is being released through the process of breastfeeding at different stages. And that often makes the milk to come in faster into the breast, and that makes the baby to swallow more often. Or when the lay down reflex is, if there's a period between the two different lay down reflexes, the baby might pause to rest, or the baby might suck several times before he swallows. But still, we have this pattern of smooth, continuous movement, suckling with occasional pauses to rest. Now, a fluttery or choppy motion is not accompanied, which is not accompanied by the sound of swallowing, indicates non-nutritive sucking. Now, a baby might suck initially. The very first few sucks that he's been attached to the breast might be a, a quick sucking in a quick succession, choppy and fluttery suction. And this might happen initially when there's not the lay down reflex hasn't happened yet. And then as soon as the lay down reflex happens, the baby starts sucking with his proper longer sucks. So fluttery and choppy motion sucks might be okay initially, but the baby is not supposed to carry on with this, and specifically when there's no sounds of swallowing. So he's not getting any milk with these type of sucks. Excuse me, we need to explain the milk ejection reflex to the mother so that she understands how the milk ejection reflex works. When the baby is sucking more, when the baby is swallowing more, when the baby is having his rest periods, so that she can also understand that more clearly. And she will see that the baby starts to swallow more rapidly each time a lay down reflex comes and brings more rapid expulsion of milk. And this is very important. She might feel, not all mothers feel the lay down reflex, as we've said previously. The mothers, we've said in the previous session when we talked about the lay down reflex, that the mothers might feel a tingling or a warmth sensation in their breasts, and other mothers might not experience that. So, but when she is being able to listen to the way in which the baby swallows, she will also understand when the lay down reflex have happened or not. Also, she might see that milk might drip from the opposite breast when the reflex occurs. Now, the very important thing here is that mothers often wonder, and it's not only mothers, midwives also often wonder whether the babies are actually receiving milk from the breast. And the best way that we can determine whether babies are receiving milk from the breast is to see whether the babies are swallowing or not. When the moment that we know that, or we see the baby swallowing, that we know that the baby is getting milk from the breast. So we need to know by ourselves what it does look like when the baby is getting milk from the breast, and obviously we also need to teach the mothers what it looks like. She will see the jaw working. Now the jaw working all the way back to his ear. We will come back to this again. And then when we look at their throats, we will see the rise and fall that occurs with swallowing. And if you just put your hand on your own throat and you drink water, for example, you can see and you will feel, if you haven't been aware of it before, how your throat works with swallowing. And that's exactly what we are looking for when we look at the babies swallowing their breast milk. Then when we look at the feeding behavior in general, we have talked also a little bit about that in the previous session when we talk about the frequency of feeding. The baby sucks in kind of three different activities. First of all, there's a rest period, like we've said, and the rest period can now before the baby starts sucking, or it can even be in between the sucking. Then the baby the baby has been stimulated by the mother's nipple. He's now having the root reflex. He's been attached to the breast, and now he starts suckling. And he starts with non-nutritive suckling, with swallowing milk, without swallowing milk, because, and specifically in the first few days, and specifically new mothers who are breastfeeding for the first time, where the lay down reflex takes a little bit to happen. We get that the baby suckling first, but without swallowing milk. And then next, the baby starts, the lay down reflex comes, and the baby sucks and swallow milk. And what we find here is that we have now nutritive sucking, which might include this fluttering suckling, but then there is swallowing as well. And then first of all, short, frequent sucking, and then eventually slow, deep, one suck per second sucking as the let down reflex has happened. And also very important is that as the feed progresses, there are pausing periods. The pausing occurs more frequently the longer the feed lasts. Initially, the pausing is short, and then later on, the pausing is more frequently because the baby is now getting more satisfied. His thirst is being quenched, is not so thirsty anymore, and is getting enough food. And then he started pausing. Now, what is very important with all these pausing is, like we've said with the very first breastfeeding, the previous session, is when the baby pauses, we shouldn't see it as the baby has been finished with his breastfeeding. We should be patient when the baby is pausing, and we shouldn't interfere while he's pausing. And then he will start drinking again as soon as the let down reflex comes. So what's very important is that the midwife should simply encourage the mother to allow the baby to pace his own feed, and that the pattern of sucking will generally relates to the milk flow. He will drink more when there's more milk flowing and less when there's less milk flowing. Now, we have talked also in the previous session, we're just going to talk a little bit more about that, about finishing the first breast and finishing a feed. Now, the baby will release the breast when they had sufficient milk from it, or they might release the breast when they're not having sufficient milk. Like we said initially, the baby is drinking and there's not a lay down reflex. It doesn't, or it's not been attached properly to the breast. It doesn't get enough milk, and then he will release the breast. Or he will suck for a while. He gets, there's the lay down reflex has happened. He gets enough milk, and then he will release the breast because he has now eaten enough. He has got enough fluid to quench his thirst, and he's also have got enough calories to make him to feel satisfied and happy. So we've said that when the infant is satisfied, the suckling pattern changes. He rests for longer periods, and he might eventually fall asleep on the breast. When choppy and non-nutritive sucking happens, like we've said before, without the sound of swallowing, the mother should burp the infant. She should take the infant off the breast, burp him, and then try and reattach him and complete the feeding. Try and complete the feeding on the other breast. Or if he fell asleep on the first breast, he can also be offered the second breast just to make 100% sure that he has got enough milk. So again, the mother can burp the infant and then also put him to the second breast. And if he's not interested in the second breast, then he can just be put to the second breast first, or with the next feeding. The baby should not be deliberately removed from the breast before they release it spontaneously, and this happens, as we've said, normally in a normal full-term baby. When there's enough milk, when the baby is being attached properly, the baby will release the breast when he's been satisfied and happy. So as long as he's sucking properly on a breast, suckling properly on a breast, he shouldn't be taken off that breast till he's done with the breast, except if the mother is experiencing pain, and the baby is not, which is the indication that the baby is not being latched properly, and then the baby should be taken off the breast and being reattached if he's still willing to feed. And then it's very important that the mother should be taught how to remove the infant from the breast. You will see it clearly on the video as well, where we remember we've said last time with the previous session, the only time that the baby really sucks and creating a negative pressure is when he sucks the nipple into his mouth. And we need to break that negative pressure before we can take the nipple out of the baby's mouth. So it teaches the mother to just put a finger in the corner of the baby's mouth to break the suction. And you, as I'm saying, you will clearly see it on the video. And then she can remove the baby from the breast. Now, the length of the feedings. Now, this depends to a very large extent on individual babies, individual mothers, lay down reflexes, the amount of milk that's been produced, etc. Now, a baby in the first weeks of, in the first few days, we've said that it's usually not so long that the baby has been drinking on a breast, but later on the baby might drink for more or less an average of 20 minutes. Now that differs to a very large extent whether he will take one breast for 10 minutes and another breast for 10 minutes, or whether he will empty one breast in 20 minutes. So it depends to a very large extent. And this should happen more or less 8 times in 24 hours. And we've said that it should not happen less than that. So if the baby is not being waking up for feeds, he should be woken up at least 8 times in the 24 hours. Now, the feeding time gradually increases as the baby needs more milk in the first few weeks of breastfeeding, and then later on, the baby, when the milk production is being stabilized, the baby is getting stronger, the baby sucks differently in the first few weeks of breastfeeding. The feeding time might increase. Now, this also, as I've said many times, depends on, to a very large extent on individuals. Some of us eat very quickly and a lot in a short time. Some of us eat much slower and less in a longer time. So this also depends on the individual baby, on how long exactly you will suck. The most important thing is that while the baby is sucking, that we make sure about the fact that the baby is sucking correctly, that he's been attached correctly, and that he's swallowing, so he's getting milk in. Now, what is also very important is to teach the mother that longer feeds does not cause sore nipples. It's not the longer feeding that causes the sore nipple, but the fact that the baby is not attached correctly, which might cause sore nipples. And that we will discuss in more detail when we talk about sore nipples. So the reasons why babies will withdraw from the breast will be that they're not correctly attached, and because they're not correctly attached, they don't get milk, and they don't get proper enough milk, so they become unhappy with that. Or the milk flow is very fast, and the baby literally needs to let go and pause a little bit before he sucks more. Or because the baby has swallowed air with a generous flow of milk, and now he just needs to stop, get rid of the wind, expel the wind, and then he will suck again. Now, how do we know that the baby, and that's another type of cue that we need to teach the mothers, that how should they know that the baby gets enough milk? Now, the baby, we've said that, and we have talked about that extensively when we talk about the frequency of breastfeeds. The baby should be nursing frequently 8 to 12 hours and 12 times during the 24-hour period. And this specifically is very important initially. And as we've said, also during growth spur periods where the baby is growing very fast, it should also be fed more frequently. A baby should be content and happy after a feed, and he should release the breast on his own. And after he has released the breast on his own, he's happy to go to sleep, and he is peaceful, and he will sleep for a while. Weight gain is expected as expected, and that's why we need to teach the mothers to understand the growth charts that you can see whether the baby is gaining weight according to his growth percentile or his weight percentile. And the baby is sucking, and the swallowing patterns, as we have taught the mother, now she can determine that the baby is sucking and swallowing. The baby has at least 3 to 4 stools a day from the 4th day onwards. And then also this might change a little bit later on in breastfeeding when the baby is getting older. But for the first few weeks, a baby normally more or less has 3 to 4 stools, which is an indication that he gets enough milk. And then also the passing of urine is a good indication for us that the baby is getting enough milk. For the first few days, first 5 days, the baby might not pass a lot of urine because there's such a lot of changes in his body regarding the circulatory system, etc. So that the baby is not excreting a lot of water and is also taking in a very low volume of milk during the first days as well. So it's only from day 5 onwards that we say that the baby should have at least 6 or more wet diapers per day. Now with the disposable diapers, it might be a little bit tricky to determine whether the baby, how many wet diapers the baby is having. Because we can't always see it on the nappy, or the nappy might feel heavy, or some disposable diapers have a faint line that changes color when it's wet, so we need to just make the mother aware of that as well. And then the baby is alert and active when he's awake. If the baby is not getting enough milk, like we will see it on the next slide, the baby is lethargic usually and sleeps a lot. So sleeping a lot is not always a good sign that the baby is getting enough milk. And then obviously when they do get enough milk, they also meet their developmental milestones when they're supposed to do so. So what are the signs that the baby is not getting enough milk? It's basically the opposite of what we have discussed just now. As I've said, a baby that's not getting enough milk might be sleepy and lethargic. This might also be because the baby is hypoglycemic. These babies are usually having very little and low energy. So this is very important, that when a baby sleeps or the baby is too sleepy to attach to the breast, it might be because they are not getting enough milk and they don't have enough energy, or they're not spending enough time on the breast as well. A baby who's not feeding well because he's not been attached well might fall asleep shortly after the beginning of the feed, or he might even suck much longer in trying to get milk out of the breast. He might feed for 30 to 40 minutes per feed and he's not getting enough milk. This is where it comes in very importantly that the mother should know when the baby is swallowing or not, whether he's getting enough milk or not. Latching is painful and it appears shallow. It's not a deep attachment. The baby has not regained weight as he should be according to his growth charts. There's not enough stools being passed per day, and there's not enough wet nappies, urine being passed per day. The urine is also not pale. It sometimes looks a little bit more concentrated. Now, there are 2 videos that you need to watch. The video shows why a good attachment is so important to breastfeeding success, and also to help the mothers to deeply attach the baby to the breast. And the second one is also, it's more for sick babies and premature babies, but all the principles, the correct principles of attaching the baby is still there. So I think it's especially both of them are very good videos, and it gives you a very good idea of what latching should be and how the baby should be latched correctly. And that brings us then to the end of this lesson. I hope you have enjoyed it. I hope you have learned a lot about latching. I hope your knowledge about latching has just been renewed again. So I hope you enjoyed it. Okay, go well.